topic of discussion is very important and very relevant. Although none of us want to face a situation like this where we have to disclose a medical error to the patient, but then we all know that there are such situations when an error has happened and it is very well in the knowledge of the patient and the patient's family, and you really need to speak to the family and talk about it. And trust me, when I even speak to seasoned clinicians, that how do you feel when you have to disclose a medical error, they are normally very, they say that yes, it's quite anxiety provoking to talk about any error that has happened in the care. Actually, today, Dr. Venkatesh called me in the evening and he shared one of his experience where there was no error. Rather, he had identified a case, of patient who could have gone into a serious complication, but he, handled it very well. But in spite of that, there was aggressive reaction, and I think when Mr. Mohan is on their panel, so they jointly handled it very effectively. But then he was quite disturbed because of the situation. So in case if he joins, maybe he'll share that case with all of us for everybody's learning that this is what these people, handled, and they kind of had to experience it. So as I said, disclosure of error is a very scary and relevant topic. If I may ask you, if you were in a flight where you were going with your family and unfortunately the flight had a near miss crash and some of the passengers, including you and your family members, were slightly injured, what would you like to know, from whom and when? Should I repeat the question? If you were in a flight with your family and unfortunately the flight had a near miss crash and some passengers, including you and your family members, were slightly injured, what would you like to know, from whom and when?
After the flight has landed, we would like to understand what was the problem with the ATC, because ATC controls all the flights, which is like moving from one place to the other. So we would like to understand what went wrong with them. But of course, it is a near miss, so we'll all be very worried, and definitely there will be some aggression which is there. Maybe we would have, after this session, we would have been more assertive after this. But then definitely, since it is a life involved, it could be in the flight or in a hospital environment where life is important. So definitely we would like to know what went wrong at the ground level, or it could be a miscommunication at the ATC level or at the ground level. So that
Absolutely. So that means we all would like to know what exactly happened, and then why did it happen, and then who was responsible for it. I think Mr. Mohan has exactly written the same thing. So that means we really would be curious to know exactly what happened, and then why did that happen, and then and especially when I say who would you like to talk about it, so definitely people who were directly involved and who knew what exactly happened. So that's the curiosity we will have, I'm sure. Similarly, in case there's a mishap or error, uh, error or any kind of complication or situation, the first desire that the patient or the family would have is to know from the doctor what has exactly happened and why it has happened, or what preventive action is being taken, or what has been done to mitigate this situation. So let me share a couple of real life situations with you where actually error happened in care, and had we been in that place, how would have we really, felt, or what would we have expected from the treating doctor or the team? Yeah. So the title of the program session, rather than writing disclosure of medical error, I've written when things go wrong. So that's where you have to really, get the courage of bringing it to the patient or the family to let them know what exactly happened. So this is a real life case that I'm sharing, where a patient was admitted to a state-run trauma center, and patient had head injury after a car accident. He was mistaken for another patient who had a broken leg. And this patient undergoes surgery for a repair of fracture which he had not sustained. Now, definitely, this is something that cannot be missed. And anybody who is like handling this case will have to really come out and explain to the family that why did this error happen and what exactly happened, and how did this patient's mistaken identity led to this kind of an error in the care. Another case, again, from one of the very leading hospitals of Delhi, two doctors were accused of failing to diagnose timely, resulting in delayed treatment and then death of a 51-year-old physiotherapist. I'm sure you must have heard of this case. This was in news for quite some time. This patient had come, with the complaints of pain in the chest, and there were ECG changes. She was a case of high blood pressure. Probably her ECG was not read properly and was not, intervened on time. And then this lady goes into cardiac arrest and she dies. And they were actually, these doctors were, actually removed for the error, and there was a case against them. Another case, a 30 years old woman, she underwent a wrong procedure after complaining for minor abdominal pain. The surgeon mistook this patient for another patient and made an arteriovenous shunt for dialysis. Again, when the actual story came out, it became very difficult for the treating doctor to go and tell the patient's family that what exactly happened. I'm sure any one of us had been there, but we would be really, find it difficult to, communicate to the family what exactly happened. So day in, day out, actually, a lot of errors happen in patient care. So medical errors like wrong site surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient, they often happen in patient care. Often happen in patient care. Most of the errors get, are brushed under the, carpet. That doesn't get to see the light of the day unless the patient gets to know or the family gets to know. But when it is known to the patient and known to the staff, that's where your actual trouble starts. So if I talk about the report of JCI, which we have shared earlier also a couple of times, medical errors are the third commonest cause of death. Almost 250,000 patients dies every year in US because of medical errors. But this is about US. I don't know about India. We haven't done any study. And if we did, where will we stand? You can easily guess. So that means this is the actual, magnitude of problem. Almost like 5.2 million medical errors happen annually in India. This is a study by Professor Ashish Jha from Harvard. Again, I think it's an estimation. Probably it's much more than what has been, estimated. Most of the errors are around either medication error or patient care and surgical errors, partly infection error. So that shows clearly that the number of errors in patient care leading to compromised patient safety and delay in treatment or break in the continuity of treatment are rampant. Only thing is we don't get to know, or the patients don't get to know, so we are kind of saved from the embarrassment. Most of these errors are because of poor communication. And I think these last sessions, 10 sessions, we have been talking about errors. And we have always been saying that we really need to communicate effectively if we need to, reduce the number of errors in patients. So let's have a look at the definition, what exactly we mean by a medical error. If I may ask you, what exactly we mean by medical error? Please write in the chat box. What exactly we mean by the word medical error? Okay, wrong diagnosis, that can be a medical error. Okay, that's one type of medical error, no doubt. Wrong treatment, yes, that can also be One type of error that can happen is when patient harm or a near miss or a potential harm happens. Yes, that's a usually criterion of defining an error. Any other understanding? Okay, errors that can or may harm the patient. Okay, any negligent act is a part of medical error, absolutely. Miscommunication between the doctor and patient, yes, that can lead to error, but that's yes. So anesthesia error, negligence is an error, wrong side surgery is an error of planning can be an error, medication error. Okay, now we are talking about the types of error that we are, you can come across. Wrong patient treatment. Again, yes, that's all part of, error. So if I may go by the definition of error, a medical error is when we fail to complete an action as intended or the use of wrong plan of treatment to achieve an aim. So when we fail to use the standard treatment guidelines or when we use a wrong plan to achieve an aim, it may or may not result in adverse events. So even near miss is an error because the patient was not harmed, but then we failed to follow the protocol. We failed to follow the advice or the standard treatment guideline. Uh, Even from the patient's point of view, even an unanticipated outcome is seen as a medical error. Although, I mean, that's possible, but then the patient might see it as an error. And I think we have Dr. Venkatesh with us who will share with us how actually very carefully he could identify a complication and correct it timely and save the patient's life. But then it was viewed as an error from the patient party side and how that led to confusion and a lot of conflict. Then omission, like Mr. Mohan just now said, neglect of duty. So when something that should have been done when it is not done, even that's a part of medical error. Now let's look at the definition of error according to the patient and according to the doctor's understanding. So according to this one of the study, the patients define the definition of error is very broad. So they don't include actually the actual error that has happened. They also include non-preventable events or complications which are documented, which everybody knows that there is a possibility of this complication. So for them, even that's an error. Patients also consider poor service quality as part of the error. When the staff is not able to meet the expectation or do not provide the quality service, it's considered as an error. Even poor communication is considered or is defined as an error according to the patient. Whereas according to the physician, the definition of error is very narrow. Any deviation from the accepted standard of care is an error. So that's the difference between the understanding both the doctor and the patient has. Now coming to the extent of disclosure, patients expect complete disclosure. So they want to know anything and everything that has gone wrong in the patient care, whether it has caused any harm or not, including near misses, where the error was about to happen and you could stop it much before time. There was no harm to the patient. The patient still want to know about what exactly. Because the moment they get to know that there was some mismanagement or something was about to happen, they are curious to know what exactly was it. Whereas physicians believe that the error that has actually happened and has caused harm should be shared with the patient. Otherwise, there is no need to talk about any near miss or anything that has not harmed the patient. For example, if you have given a medicine that hasn't caused any harm or that's not likely to cause any harm, very few people think that we need to tell to the patient that by mistake I gave you this medicine or I've given you overdose of a particular medicine. If you think that overdose of the medicine will not cause any harm. So that's the difference between the two parties. Now, when it comes to how should the yes, Dr. Dixit, you want to ask something or say something? Yeah. Please unmute your device.
Yeah, if I could contribute a little bit here, because with anesthesia, this is what we are dealing with day in and day out.
Sure.
Now, according, what happens with us is there are two forms of, systems of medicine. Let us say there is what we call as the British system and the American system, which are almost poles apart. We
Mm.
tend to follow the British system because they've made our laws and everything.
Yeah.
So now, by books, I mean, this is what I'm quoting, what is written in our books. If a patient asks me that, if you give me anesthesia, can I die?
Mm.
So the possibility is more than 1 in a million, which is the same possibility as would be if you walk out of your house today and be struck by lightning and die.
Yeah.
Okay, whereas things like, can I cause, when I'm intubating or when I'm giving GA, can I lose a tooth, can I have
Yeah.
sore throat, can I have this? So the chances are anything between 1 to 100 and 1 is to 1,000.
Yeah.
So by there again, I am very clear in saying that by in their law, because they
Yeah.
are more clear, we in India are not clear. By their law, they say, well, anything that is the possibility of more than 1 in 1,000 should be
Mhm.
told to the patient, and you will not be held liable in case
Yeah.
have not told.
Yeah.
But if I don't tell a 1 in a million sort of a possibility
Yeah.
of an error, I would not be held liable.
Yeah.
This is just what the book says, so just thought I could just contribute to that.
Absolutely. Absolutely. So the point that you have made is very valid, and I think all our medical system still follows, not just the medical system, lot of rules and regulations and laws, and even ethos we follow from the British culture, because we have been ruled by them for more than 200 years. So that has gone deep down into our DNA, and will take a lot of time to get out of that, a thought process. But again, we need to really update our knowledge and ways of dealing with life. There was a time when patient never asked about anything, and I still remember we used to say, nurses, please go and get this consent taken from the patient. Sister, consent le lena patient se. That used to be the way the instructions were given to the nurses. That was when the patient did not ask. When that was the time. The law was same. Maybe law has been modified more in favor of patient and empowering the patient. That's all right, but practice was more or less where the patient was not explained much, because patient always believed that whatever is being done or will be done will be in the best interest of my care and health and my welfare. So I don't need to doubt, or I don't need to ask, which is all right. But today patients are aware. They want to know. They are curious to know. Now, if the patient has asked me this question, that is there a risk of me dying? Like the way you explained to me, in the same manner, we need to explain to the patient. See, there is a risk. If you ask me about the documented risk, yes, there is a documented risk. But the risk is 1 in billion. It is as much as the risk of walking on the road and dying because of lightning. So, what happens? You have not given incomplete information. When you give complete information, patient gets this understanding, okay, there is a risk, but it's not as high as this. So again, explaining is important, answering is important, addressing their concern is important. Now, whether you tell each and every risk involved or not, that's again not practically possible. Even if I say yes, the if we go by the book, we have to tell every possible risk to the life, but we know practically that's just impossible. But at the same time, if we have good rapport, if we have addressed their concern, if we see that the patient is anxious, they want to know more, if we patiently address those questions, I think they go back satisfied. I think in total, I think this is what we have to focus on. Now, even when we are talking about the error, how should the disclosure of error happen? The patient says that it should be done in a truthful manner. Honestly, tell me everything. Even if you have gone wrong somewhere in your duty, I want to know. At the same time, they expect the treating doctor or the team to be compassionate and more concerned and understanding. Whereas physician's attitude is that even if I have to tell the error or complication, it has to be done in an objective manner. That this is documented, this has happened, this was already told to you. Then also with minimal disclosure. So if you will look at the kind of disclosure we do, we don't like to tell a lot. We try to keep the information as little as possible, and also what the patient actually asks. Otherwise, we avoid all of the information. And then, in a very matter of fact manner, more like, in a very technical language, so that, yes, I have communicated that this is what exactly has happened in your case. Now, naturally, if I'm being very minimal in my communication, and if I'm communicating in a very, technical manner, in a very matter of fact manner, how much has the patient really understood? How much has the patient really been benefited? You can very well imagine. Now, coming to the role of apology. When we look at from the patient's point of view, all patients expect if something has gone wrong, please, you must apologize. Whereas, if I may ask all of you, what do you think? What is the general fear about thinking about apology? How many of us are really comfortable and happy about apology?
Many of the patients may not accept apology also at this point of time.
There is a possibility, especially when they're very upset, there's a possibility that they may not accept our apology. We'll talk about that. And that's where they will become aggressive and they are very upset about it. But in general, how many of us think that, yes, apology has to be tendered? We have to apologize. No? Dr. Paneer does not agree?
No.
We don't have to apologize?
Actually, even if you tell a very small error,
Yeah.
which has not caused any significant problem to the patient, even if it becomes a til ka taad and he creates a ruckus. So a very senior surgeon in my city explained when I came to my practice, never accept your errors in front of your patient. आपने अगर कुछ भी छोटा सा भी error किया है, I tell you, a very small piece of suture remained into the eye of a patient, and next day I removed it, and it was a very small piece, and it becomes an issue. It has not caused any problem. So if you accept your error, there are thousands of errors we do, but the main thing is your result should be good. If your result is okay, I don't think there is any point in accepting errors with the patient.
I think that's debatable, and we would not debate on it. And I completely understand, because each one of us come from our own experience and the kind of clientele we are dealing, and the concerns that we have. Definitely, even these studies show that we are concerned about, if we tender apology, it can become a legal liability. So we fear that it's not good to admit that, yes, an error has happened. But the thing is, a lot of time the situation is so clearly visible that there is no way that you can say that it was a complication. For example, if you were supposed to operate on the right leg and you operated on the left leg.
That is something which is...
That's what I'm saying. So even in that case, how far do you think, tendering apology would really is advised or not advised? That was my...
There is no choice. You have to apologize.
No choice. So that means there we know that we have to kind of, at least feel sorry or say that we are sorry for what has happened to the patient. We'll talk about it in a second. I'm just trying to tell you the result of a couple of studies that tell what exactly is the situation and how people, view it, and how patients think of it and how physicians think of it. So when to have the conversation? Patients feel that, yes, it should be done immediately. Like when I asked you if you're in a flight and if something went wrong during the flight, when would you like to know? And most of you said, as soon as we land up, we want to know what exactly happened. So similarly, even patients want to know immediately what has happened. Whereas the physicians think that when I have all the information with me, that's the time to, tell the patient or the family what exactly happened. So if I may ask another question to you, what do patients expect? What do you think patients expect? Write in the chat box when it comes to disclosing of medical error. Okay, how and why mistake happened. They expect the truth, and why it happened, they want to know. Absolutely. Absolutely. What more? What more? Compensation in all forms. Yes, that's also one of the things they ask for. They ask for compensation. Then presently, all patients don't trust it completely. Yes, I completely agree with you, Dr. Shishir. That's one of the challenges we're facing. Total transparency and courteous behavior and concession in invoice. Yes, that's one thing they normally, bargain for. I agree. I completely agree with you. Then, of course, they're asking for more transparent, exchange of information. Absolutely. Anything else that you think that they ask for? I think most of the points you have covered. Let me just show you the list about one of the study that says that yes, they desire full disclosure of harmful error because they want to know what exactly happened. Also, statement that error occurred. So somewhere they want to know, they want us to admit that yes, error happened. That's what they want to know. Details of what happened. So what they want to know in detail, what exactly happened. Then implication to their health. So how is that going to affect their health or recovery or lifestyle or other changes? They want to know about everything. Why it happened. They want to understand about that also. And then how will reoccurrence be prevented? So a lot of times they have this curiosity. How will you prevent this error from happening again? And then of course they want apology. That's the usual expectation you will see among patients when if anything goes wrong in their care. Uh, Most of the doctors say that yes, we should be, coming out honestly and openly and telling about the error, but only 30% of actually do disclosure in real sense. Because we all know there are a lot of concerns about disclosure. So studies suggest that three-fourths of the errors are not reported. Also, even if disclosure happens, it never meets the patient expectation because the way we disclose and the way patients expect, there's a huge gap between the two. And also, we don't have any proper formal training for doctors where we train them how do you go about disclosure. So naturally, if there's no training and they have not learned, so everybody does it as per their understanding or their learning or their training. So, if I may ask all of you to share, or some of you to share your experience, like the challenges that you have met or seen, this has happened with you or any of your colleague, that will be really a good learning for all of us. I think we could have Dr. Venkatesh to talk about the situation that he was sharing with me in the morning. So, I mean, although it's not exactly disclosure of medical error, but it is something that was about to happen and how he handled it that really was very enlightening. I think Dr. Sheetal also has something to say. Dr. Sheetal, do you want to talk about a situation where you handled a disclosure of medical error?
Yes, ma'am. I could.
Okay.
Yes.
Okay. And any experience where you tried doing and it didn't work out well, or
Yes.
or maybe things went really wrong and you were
Yes.
clueless how to go about doing it. So, okay,
Yes,
I think let's start with Dr. Sheetal and then maybe Dr. Venkatesh can talk about today's the case that he has recently witnessed. Go ahead, please. Yeah. Yeah.
So yes, this is an error. This is a situation where a patient had an intracath. Now the intracath was put by my resident year 2.
Hmm.
And unfortunately, the intracath was difficult. Some patients don't have very easy IV accesses. And unfortunately, we had to take him under anesthesia and, do the IV.
Hmm.
Now, IVs post surgery can be very, very painful, specifically 1 or 2 pricks. That's the easiest and the simplest thing. See, from the patient's perspective, it's the simplest sort of procedure in the book
Hmm.
when it comes to, a medical kind of a procedure.
Procedures,
So
yeah.
he was, how could this go wrong? I
Hmm.
have had anesthesia in the past, and I have never had such a pain, so much pain in my hand. he seemed to call me the beast of Benin. I don't know why that means. He was very aggressive. He said, "You've put it on my right hand." Unfortunately, ma'am, we did try to put it on the left hand, because you should always keep the patient's working hand, free. You've used my right hand. I am unable to write. I'm unable to work, and I think I am really going to bring this up with the management. He did bring it up with the management. I was called there, and the only thing I could say is, yes, we are sorry for this. Unfortunately, your venous access was difficult. We tried twice. The anesthesia, when we gave the anesthesia, the veins sort of dilate, and that's when we could put it. And that's all we could say, ma'am. He was very, very aggressive. The only thing we could do is, listen to him and everything, because yes, he did have fair amount of thrombophlebitis. I completely agree. But on the flip side, just for discussion purpose, it is a possibility. Venous access can really, really be difficult and can be a nightmare for us as anesthetists, even nursing staff, everybody. So yes, it was a bad experience in the sense I went back with a lot of grief, and of course he did not press charges. He did not sue me as he wanted to. He said all that. I think the anger came out, but yes, I was. Yeah, the management was a little aggressive in a sense. Yes, they did say that we've taken action and this and that, but that's how we handled it. I think that's. Thank you. Yes.
So see, it's a small thing if we talk about, it's a small thing, but then patient can get furious, and especially when they are hurt, and they have been injured because of that, and they suffer, because of any. It's not an error, actually. It's not an error, but then the patient views it as an error on our part in executing the treatment. I completely agree. I think Dr. Venkatesh would like to share his case that he managed. I think he managed very well, I would say, when he was narrating it to me. But see how things sometimes turn so, ugly that they really go out of hand. So, Dr. Venkatesh, if you're comfortable, would you like to share the case?
Yeah. Good evening, Dr. Indu. Thanks for giving me this opportunity to share my ordeal, what I went through in the last week or so. This was a case, Gravida 2, previous LSCS. It was a planned cesarean section, and the first cesarean section was done by me in an earlier institution, which I quit about 4 months back, and I have joined a new institution in the same city. So he was, I would like to highlight the profile of the husband of the patient. He used to be my colleague in the earlier establishment. He used to be in charge of the liaison, security, and VIP movement. In fact, our hospital in Bangalore was catering to very high profile, something akin to Breach Candy in Bombay, or one of those elite hospitals in Delhi. So that kind of a patient profile we used to have, and he used to handle the public relations and VIP movement, and was in charge of security. So that was the profile, and he followed me because he had a very pleasant first delivery experience. It was a trial labor which ended up in section, but this time around the wife didn't want to go through a trial, vaginal VBAC. We call it as vaginal birth after section. But then we planned, it was a planned section, went on well. It was a Sunday. We obliged. Again, elective surgeries are not done on Sunday, but as it is common everywhere, these days they go to an astrologer to fix a muhurt. And according to the date and time, we catered, and the outcome was good. It was an alive. First one was a male baby. This was also a male baby, and the anesthesia, the immediate post anesthetic recovery, the surgery part hardly takes about 45 minutes, and by 1.5 hours, she was back in the special ward that they had opted for. And being a Sunday, I told my associate who assisted me to come for an evening rounds and check up. And as I have done my training in an RV setup, the rule there is whoever does the surgery has to owe the responsibility. And we were trained to do a night rounds when there's nobody trained or as experienced as you are. And I have made it my routine for the last 30 years that I've been practiced. Whenever I operate, I usually come late around, say, post-dinner, 10, 11 o'clock, for a routine rounds, talk with the patient, listen to their grievances, if any, and make sure that they're comfortable. And, that's the kind of routine. And on Sunday, when the evening rounds was quite uneventful, that's what the picture was painted by my associate. Obviously, she might have missed getting into the depth, because apparently patient was maintaining hemodynamically stable, urine output was good, and the pain part of it also was taken care of. And night when I came for rounds at 11:30, I found her pulse to be slightly on the higher side. It was not alarmingly high. Hemodynamically, if you can sum up, she was still stable. However, she just pointed out at a particular area and said that this part is, I just saw the dressing and it was clear. There was no oozing or anything on the cesarean section wound. And as a part of the examination, when I asked her to show her tongue, it was apparently pale, very pale, not proportional to the blood loss that had occurred on the table. So by somewhere in my mind, I ticked that, and hemoglobin and hematocrit should be done as early as possible. And I told them, patient is now very comfortable. It's 11:30 in the night. Her pulse is maintaining. BP is well above normal. So anyway, just to be on the safer side, get an emergency HB done when the patient wakes up around between 5 and 6 in the early morning, and inform me as soon as the reports come around. So having said that, I left, and by the time I reached home, it was 12, and I get a call by 6:30 telling that her preoperative HB prior to surgery was around 9.8, and it had dropped to 6, almost 6. So that's a 3 gram percent drop. So that again made me alarm to follow some follow-up and on a priority basis. And I asked my associate to come early to the hospital and his duty doctor to post for an emergency ultrasound scan. But unfortunately, our hospital doesn't have a full-time ultrasonologist on call, and the entire radiology and ultrasonology department, it's a startup. It's just a 2-year-old hospital. It's still in the evolving phase. They have outsourced this radiology section to a well-established group of radiology providers. And the earliest they would come is 8:30. Though it was suggested that it has to be done as early as possible. The 8:30, the person comes, does an ultrasound, and we found there is a hemoperitoneum of about 250 to 300 ml. And we also come early. Usually I come by around 10:30. My assistant comes by 9 o'clock. And by the time we decide and, seeing her this thing, I thought a relook laparotomy is a mandate because by that time, her tenderness on the side where we suspected some intraperitoneal bleed was a little more. There was a pointing signs and there was a little bit of gaseous distension. The bowel sounds were a little sluggish, and I had kept her nil orally since the time I saw her last in the night. So I explained to him what might be the possibility, and I also disclosed that there is a collection which I need to sort out. I need to see myself. It can't be managed conservatively. The fact that there is a 3 gram percent drop is to say that, and it is corroborating with the amount of hemoperitoneum that is suggested in the ultrasound. So I took up for the relook laparotomy, and true to my doubt, there was a small vessel spurter at one angle of the uterine incision, which was just 1 or 2 figure-of-8 stitches, corrected that. However, I again exteriorized the uterus to see whether there's any broad ligament collection or any other source of bleed. And to my this thing, there was no such major source of bleed except for that particular ankle. And we finished the surgery again in next half an hour to 40 minutes. This was done under general anesthesia. The first instance, the surgery was done under regional block, and the second surgery was done under GA. So obviously the anesthetist for both the surgeries were different, and the surgery, the recovery time post anesthesia took a little longer. She was put on CPAP for some time. The entire episode from the time the patient was got into the OT and then got her out, and decided, seeing the amount of pallor, we wanted 2 or 3 back-to-back pack cells to be run. So we thought it is prudent enough to keep her in the ICU rather than back in the ward, so that she gets one-to-one attention by the critical care team. And within next 24 hours, she recovered very nicely, and she was shifted to the ward. And but the complaining nature of the patient didn't stop. I mean, she was basically upset as to why so many bloods were transfused. I did give her the reason, and I told what was done also in simple layman terms. Everything went on well, and over the next 4 days, the usual cesarean section package is for 4 days, which we charge. There is a sum of say about 1,10,000 or 1,20,000 for a 4-day package, excluding the baby. Baby was also fine, so baby didn't have any issues. She couldn't feed the baby, so top feeds were given. And by the day of discharge, it was extended by 2 days. So on the 6th day, when she was fit for discharge, everything was fine. The problem, as you rightly pointed out, madam, we had not asked the patient to pay any deposit because he was under some insurance. So insurance patients are not made to pay any hefty deposits or anything, unlike cash paid patients, where at least 75% of the total estimated cost is being made to deposit. In this, we take a token sum of say 5,000 rupees, and we send for the approval for the insurance company, which usually within 24 hours we get a reply saying this patient is eligible for this amount of maternity benefits. And it was a private policy, it was not a corporate policy. So having said that, and when the bill of around 2 or 2.5 lakhs was subjected to him, and that is when he became upset. He brought in his brother-in-law, who looks very antisocial kind, and they started creating ruckus. And I was trying to explain, being the director and lead consultant of the department, I had some leverage to let off financially, write off some amount of the final invoice that was presented to the patient. And in spite of it, I think they had pre-planned it. They started creating ruckus. They started documenting, taking pictures of the case sheet. And though the brother-in-law had nothing to do with the patient as far as admission and policy, decision making was concerned. But this person, I think the husband, had purposely got for some kind of a moral strength or to argue or create ruckus. And there was a big commotion that he created in the common areas of the hospital, for which code violet was being initiated, and then came the security personnel. He was very violent, all of which has been captured on the CCTV system of our hospital. And then after, in spite of having a boardroom meeting in presence of the CEO and the chairman of the hospital, he refused to budge, and he said, I want to know the reason why the second surgery was done. He told, he will throw the money on our face, but he wants the reason as to why the second surgery was done. Okay, then we told, you pay the money, we'll give you the entire copy of, the discharge summary is yours. There's no need for you to copy, and then we'll give you the reasons. And if you're still dissatisfied, you can lodge a complaint against the hospital or the doctor and fight your case in the medical council of our state. So he, being a medical personnel, he knows how these hospital systems work. He waited till all of us left, and he just got absconded. And we had to file a complaint of under column 450, 420 of IPC, and other this thing wherein my good friend Advocate N.C. Mohan intervened, and he took the condition and he advised us as to how to go about in the next coming days, and what all the legal implications are there, and where we stand in this whole scenario, because he happens to be the panel legal consultant of our hospital, and with his help, we could tide over the situation. And initially, the police tried to call both the parties to the negotiating table. It seems it is their duty when such conflicts come up, first to pacify both the parties and to reach some kind of an agreement. And if it fails, then probably, because he was also politically connected, I told you he was in charge of the VIP movements, and he was the PRO kind of a person. So he spoke to the MLA, he spoke to some DGP of the state, and given he's painted his picture. But then when our Mohan sir tried to intervene and tell that if the police station or house officer doesn't take the complaint, then he might have to file the petition in front of the magistrate to accept the complaint from us. But following days, after 1 or 2 days, probably the inspector got to know as to what exactly the picture was from both our perspective as well as his perspective. And then he finally accepted our FIR. And now I think he still, after almost 7 days, he still didn't come for the follow-up. He has not collected his discharge summary. He has not collected anything, and he is not paid also. Paid the outstanding dues that are due to the hospital, and probably it is now ready for a legal battle. Probably, I think Mr. Mohan will be able to elaborate on whether this was a preventable one. And as you suggested, due diligence had to be followed as far as the IP billing people were concerned, where on an event basis, on a daily basis, they could have raised an invoice and collected what was due for the hospital in small installments, where this would not have precariously grown into this extent. And that was the omission on our part, I suppose. But as far as engaging him on a day-to-day basis, the due diligence was followed, and twice a day we used to go, and we didn't show any extra concern or this thing. We treated them as one other case with whatever we do. I mean, we didn't show that we were guilty or we have done something wrong. He also understood perfectly. Probably he would have been most happy if we had written off the bill and said, okay, please go. But then I would have set a new precedence, and probably he would have gone and said, my bill was waived off because my wife had to go through a second surgery. Some bad mouthing he would have done, which according to Mr. Mohan, he said, no discount should be shown to such people who are rude and who have caused some disruption in the common area of the hospital. So much so, the code violate had to be initiated. So this is the things. I want feedbacks from other participants apart from Indu madam, because we had a long discussion in the morning as to how this could have been prevented, or what other measures I or my administration should have taken to avoid this unruly
episode in your thing. So I think we have actually a lot of issues coming out of this case, but I think we'll focus specifically on the communication part. If I want to use this opportunity to understand where did we fail to communicate, because ultimately it led to a confusion that as though we have not explained them, as though we have not updated them about the possibility of the bill, as though we have not discussed this thing or have not taken their consent. So that means there was either actual communication gap, or the patient used this opportunity to project as though there was a communication gap. So I would want all of you to just focus on that particular part. Where do you think we failed to communicate? I mean, how could have this whole thing handled in a proper protocol where for example, disclosure, it's again not a medical error. It's not a medical error. It's discussing about the complication, explaining them about the complication. How could have this been done differently? If anybody would like to share their thoughts on this.
Post the first surgery and the second surgery, the timing, I think that would have been handled in a much better. Maybe it would have been more transparent if they would have called that such a thing has happened and this is what we are planning to do. This is the second surgery why it has to be planned. That time could have been very vital, so that things could have been handled in a better manner that time. I thought that is the.
Dr. Vanshi, I think there was no time wasted.
Okay.
Due diligence was followed. It was picked up. The problem was picked up in the night, and we came to a conclusion in the morning. And once the scan was done at 9:30, 10:30, she was in the OT theater. So, and every step, the husband kept on telling that no relatives of theirs, that is in-laws, the girl's parents or brother-in-law, nobody has to be told about this, and he will take the decision, and that he will later tell them. So much so, he specifically instructed his relatives not to come to the hospital for the next 2-3 days, and that's what precisely he did. So it was solely between me and him and his wife. Only 3 of us knew as to why we took them for the second surgery and what was the need and what I did. Everything was transparent. So it was
I'm
not.
sure all this communication was documented.
Yes. Everything is on the case sheet. Even it's mentioned in the discharge summary, the course in the hospital, the need for re-exploration, the giving of blood, keeping in the ICU, and everything is nothing, no hide and seek as far as this case is concerned.
Yeah, at the time of second consent taken, extensive discussion about even expense would be.
Expense was not discussed. That is a major omission from my side, if at all you consider that as an important thing. Probably what happens in my earlier institution, all the expenditure part, there was a separate portfolio called as IP billing manager or floor coordinator. So they used to come and discuss the financial part. And I'm not used to discussing the finance part right from my earlier assignment.
Yeah.
Probably here I should have thought about that well in advance. And as the saying goes, familiarity breeds contempt. So this was a colleague of mine. So probably he, I thought, I took him for granted, or he took me for granted, and so no financial. And the person IP billing in charge, all the 3 are from same institution. We have all moved. Of course, this man was jobless, but the 2 of us, the IP billing manager, she has joined this institution as soon as this project was launched. And I am the latest entry in this bandwagon. I joined about a month back. So I'm still new to the system. But it's usually, I never used to discuss the finance. Finance, I used to say, there is this person designate, you please go and discuss there.
So,
Mohan, your input, sir?
Sorry, I joined late, and thank you. Mainly, he tried to capitalize on the fact that he had contacts and the fact that some people in the new institution knew that he had contacts. They would readily accept that. Yeah. And he saw this as an opportunity to negotiate and get some discount. And probably there was a conspiracy amongst the husband and the brother-in-law to try and bend and mend their way through to get this discount. To keep it short, I would put it this way. They tried their best. The hospital, including Dr. Venkatesh, have tried their best to talk. They were invited into the boardroom, etc., etc. But they wanted their way out.
See, once their job is done, they have nothing at stake.
Exactly.
To understand that.
All this happened only after they saw the invoice.
The patient was fine, and
everything, mother, baby, everybody is fine.
So that means, I think the learning that I have from your case, Dr. Venkatesh, one is that when we communicate, we need to talk both about what has happened, and then what is that we are going to do, and then how much it is going to cost to the patient's family. So that cost factor has to be, discussed. Even if you say I am not used to it, there has to be somebody who has to address this to the patient and let them know. Maybe after listening from them, they'll come to you and request you to kind of, reduce or maybe give some discount. That probably you can give, as you said, that you have that leverage. But this has to be, I think the learning from this example is that if there are financial implications, they should be discussed right then and there itself. So that's one learning that I have from it. Dr. Puneet, you don't agree? Please unmute and speak. Unmute. Please unmute your device. Yeah.
Whenever there is a complication, as it happened, you do not know what will happen during the surgery. How can you plan a surgery beforehand in such a complicated situation? Doctor did an extremely good job, and the outcome was actually for these people. I mean, why should we always be defensive when we have not done anything wrong? That is the reason. I mean, they know this person knew that he can create a problem because he knew the medical system.
That's what I'm saying. So what we are talking about, Dr. Puneet, we're not saying whether we are right or wrong. What we are trying to learn is how can we proactively handle situation like this. That's what we are trying to discuss. So I'm not saying Dr. Venkatesh should have talked about the financial part, but there has to be a system where financial counseling is simultaneously done when the patient is, of course, as we don't know when we are going to operate.
मैम, क्या इस आदमी को ये जो अस्पताल चला रहा है इतने सालों से, जो मरीज अटेंडेंट था, क्या इसको पता नहीं था कि ये सर्जरी एक्स्ट्रा होगी तो उसके पैसे एक्स्ट्रा लगेंगे? इसमें क्या बताना है उस आदमी को?
एक मिनट, मैं ये कहना चाह रही कि इस केस में या इसके जैसे सिमिलर केस में अगर हम फाइनेंशियल काउंसलिंग साथ साथ करते हैं और साथ साथ में then we also ask the patient party to pay some portion every day. I've seen a lot of hospitals, they raise their bill every day. Correct. They ask the family to pay a part of the payment so that they get to know whether the family can afford or not, or if they have any objection. And also there is some security that, okay, if 70 to 80% of the money has been, recovered, even if we lose, it's just 20 to 30% of the money. So see, what I'm trying to say that there are not that he did know, and he also knew how to use those tactics to bargain and also run away after the patient has recovered, to run away and thinking that nothing can be done and nobody can stop me, and I have the support of MLAs and all the bureaucrats and other police people with me. So that is there. But then from each case we have to learn how do we whatever we have seen, how can we use it to learn. That's what we are trying to discuss from it. Mr. Mohan, I think you wish to say something. You have raised.
Yeah, very short and very important, since there are so many healthcare professionals here. A time has come where we should have a non-negotiating zero tolerance policy towards violence in Medicare institutions. The time has come. And therefore, even I I put my foot down and said, no, this man is not going scot-free. Yeah, thank you.
Absolutely. So because you had not faltered anywhere, like Dr. Venkatesh, very, the way he said that he goes for night round, and right at the night round, he could identify that the lady looked pale and she needed, investigation, and maybe she needed surgery the next day. So he followed all the possible protocol that was required. So nowhere we can see anything that he missed to do or he did not, act proactively or responsibly. So especially in this case, you can always, take a stand and say that we are not going to let go, and he will have to really pay for it. So, but then learning from this is how to see that such situations don't happen. The larger learning from this is that how can we reduce the possibility of such situations. That's what we are trying to talk about. So going back to the topic of disclosure of medical error, please remember we are discussing disclosure of medical error because we have digressed from the issue. And I know, but then this case was so real, real-time case. So I thought everybody should get to understand and see and learn from this case. So I requested Dr. Venkatesh to talk about this case. So my question to you is, when you have to disclose an error, so Dr. Venkatesh, if I may ask you, it was a complication, and I'm sure that's a documented complication. Even then, did you have any element of anxiety or fear or difficulty in communicating this to the husband, especially for the first time when you had to say that I think there's a bleed inside, I think we need to get the ultrasound done, and after ultrasound, You confirm that yes, there was a intraperitoneal bleed and the patient needs to be operated. Was there any element of
No, madam. Though I'm not used to, I mean, obstetricians in general,
Yeah.
specifically with my kind of experience over more than 3 decades.
Yeah.
I don't know the last time when I reopened, I had to do a surgery a second time for the same patient, probably more than 20 years back, or I don't know. I don't remember in the last 1 or 2 decades that I have, but there's always a first time. To that extent, I know to err is human, and I might have. But one thing from the patient point of view, she failed to record or tell us that in the last 3-4 days she had some bronchitic symptoms. A cough was the main thing. Sometimes we know patients with chronic cough or can end up in a situation like this wherein sutures can get a little loose, and it was a very minor this thing, but with a big what you call as a complication or a side effect, whatever you call it. And
so like you said, it's 31 years of experience, so definitely by now you are very confident in handling adverse situations. But if I look at it from doctors who are very young, who are just beginning their career, and if something like this happen in their life, what exactly will be their concern? So if I may ask this question to all of you, what are the clinicians' perspective? Like, what are the concerns on the clinician's mind when it comes to actually going ahead with the disclosure of error? So I think Dr. Praveen is also a surgeon, Dr. Puneet is a surgeon, and Dr. Sheetal is an anesthesiologist. So what do you think are the concerns if you have to go about, telling that, okay, the error has happened in your case? What do you think are their concerns?
I think, ma'am, I very recently also had, I just feel from a clinician's perspective. I mean, I've had this experience for the past many years now. The acceptance that an error can happen uh, is little low from a individual perspective. Lots of times we believe that this cannot happen by me. It is possible. It is possible because I've been doing the same thing over and over again. I have that unconscious absolute expertise. I can give a spinal, keeping my eyes closed is what I feel. But at the same time, that is the reason that first from my side, I would say this cannot happen. Once this, so that self acceptance is what I have seen sometimes, that no, it cannot happen, no, it cannot happen. And lots of times it can happen with post-operative infections. We keep giving antibiotics, we don't, kind of go in when we should. This is, I've seen this in yes, a lot. It is possible. Secondly, when I have to go and sort of go and approach the patient and tell that person, I think it should be as a team, ma'am. A team gives you more strength. It's important, and I think it needs to be rehearsed. It needs to be, okay, this has happened. This has happened, and it needs to be sort of, we need to be on the same page. And it's not like, we're being defensive here. No, we are coming and everybody is on the same platform. I'll tell you why it's important. Because, if every doctor or every healthcare worker is going to say it differently, I don't know what the other person has said, and this is exactly what they're going to use. Unfortunately, this is their trump card, मैम. ये इस डॉक्टर ने तो मुझे ये कहा था, आप तो ये कह रहे हो. तो मेरे हिसाब से इसको एक जैसे हडल करता है विराट कोहली अपने टीम के साथ, तो मेरे हिसाब से वो ऐसे कुछ करके this would help us. मेरा ये frank मानना है.
I agree with you. So if I may talk about from the clinician's perspective, I think talking about error is not easy because it actually causes a lot of embarrassment. There is a concern that they will be, they'll be talking about it. My staff will talk about the error. they will talk about me as being a careless doctor or irresponsible doctor or not very concerned and compassionate. And we know that there is a risk of aggressive reaction. So that also concerns the clinician, that there can be any kind of reaction coming from the patient party. Of course, the risk of litigation is also on the mind of the clinician, because we all know the moment the patient party will get to know that an error has happened, there's a possibility that they may go to the law and sue us and create problem for us. So the focus is usually on covering the error. Usually we try to avoid talking about it. And this thing, it's not just the the new doctors or still the young ones. Even very seasoned doctors have similar concern. We may vocalize, we may not vocalize. Like you said, there's a denial that how can something like this happen by me? So it cannot happen. Or like Dr. Venkatesh, when he says that, I mean, this is probably one or the second time that I have to operate the same patient for the second time. Otherwise, it has never happened. So there is a feeling of confidence that I can't go wrong, but then there's always a possibility of error and can happen, and it causes a lot of uncomfort and distressing for the physician or for the clinician. So what are the common barriers to disclosure? What do you think are the usual barriers to the disclosure? If you could write in the chat box, we'll have more perspectives coming from all of you. What do you think are the usual barriers to disclosure? Yes, definitely. Fear of criticism. Very right. Acceptance of error. Fear of confrontation. Yes, the family might confront us. Showing our weakness. Yes, absolutely. We don't want to talk about our vulnerabilities, and we feel weak when we have to admit that I have failed. Insecurities of what will happen if I disclose. Absolutely. Fear of response from the people. They might become aggressive or they might retaliate and talk ill about this. Then human nature is nobody wants to accept his error. Yes, I agree. That's one of the common reasons we think that, I mean, I can't go wrong. Fear of confrontation. Yes, Dr. Praveen, I agree with you. Violence is also a concern. Feeling that it may go unnoticed. Yes, so we feel it may not actually get noticed. So what is the need to talk about it? Yes, organization may view us as irresponsible or not a very good doctor or a good surgeon. That can be. Is that what Dr. Himanshu you are trying to say when you said organization? If you could explain by unmuting your device.
Yes, ma'am. That is what I feel, because the perspective changes the moment you are accepting an error on behalf of a medical team or maybe a surgeon per se.
Yeah. So that means there's a risk that people might view you as irresponsible or not a very good clinician.
Yes.
Absolutely. Yes, Halal, I agree. There's a fear of violence and how others are going to perceive me. That's the major concern we all have. So I think all of the things that you have covered, except few, for example, there are people who are actually skeptical of the benefits and believe that disclosure is unnecessary. So they feel if an error has happened and if we have corrected it, where is the need to tell the patient? Why should we talk about it when we have already corrected the error and it's not going to have any benefit? Some people also think that it's going to add distress to the patient and the family, so it is unnecessary to disclose. Also, when certainly the patient is unlikely to find out, we think there is no need to tell about the error. There's a risk of retribution. As you said already, patients and the colleagues might view you in a bad light or may talk ill about you, may take action against you. You fear legal action and financial judgment against you. You fear having to handle patients' emotions. Patient might start crying, patient might become aggressive, patient may start becoming, patient might become violent and start physically fighting with you or with your team members. Then also there's a belief that disclosure is primarily a factual conversation and not a complex, intimate conversation. So as a result, a lot of people, think that it has to be done in a very mechanical manner, and there is no need to talk about the emotions and talk about the impact of the consequences of the error. And then they believe that the outcome is not related to the action on the part of the person disclosing. So person might think that that's not my fault. So this has happened with you, and that's not my fault. That also is the reason when people don't effectively disclose in the right manner. And then there's lack of training in error disclosure. As a result, many of us do not know what is the right way of disclosing it. Evidence suggests that actually, skillful conversations and follow-up can reduce the risk of litigation. And a study by Harvard suggests that only 3 to 5% of the patients who are actually injured by the negligent care actually sue. Most of the patients actually just ventilate, talk, and if they are pacified correctly, they go, satisfied, and they don't go to the extent of swaying it. Now, somebody tried to understand why do patients sue. So studies suggest that the most important factor for the people to decide to file a lawsuit is not negligence. It is ineffective communication. So where they feel that there was lack of empathy and they were not treated well, there's a possibility that they may think of suing the doctor or the hospital. And also when they feel the actual information has been withheld and they have not been shared the complete information, that also can encourage them to, go and sue the doctor or the hospital. So talking about the full disclosure policy, actually there are a lot of studies that support the full disclosure policy. So I'm sharing this one of this study done at the University of Michigan in 2002. So they tried implementing a full disclosure policy where the patient needs to be informed very honestly, very fairly to what exactly happened in the case and how it was handled. And to everybody's surprise, they actually saw a fall in the annual litigation cost. So across 2001, when they were actually, not following the full disclosure policy, 2002 they implemented, and the second reading they took at 2005, they saw almost the annual litigation cost going down by 2/3 of the cost. Even the average time to resolve these cases became almost 50% of what it was earlier. And the number of claims also went down to less than 40% of what it was earlier. So that's a very encouraging, report. And lot of other studies also show similar result where a full disclosure policy actually has brought down the number of cases and the litigation cost and the time that is spent in managing these cases. Problem is probably we don't know the right way of doing it. We don't know how to handle it in the right manner. That's why it misfires and can lead to all kind of consequences. So I'm going to share a set of guidelines with you. This is based on the recommendation from the Canadian Patient Safety Institute and UK's National Patient Safety Agency. So these guidelines help us in knowing how exactly you go about doing, disclosure of error. So first and foremost thing, we need to prepare ourselves. So we need to really self-check in that am I ready to talk about disclosure? So if I am not confident, if I'm scared, if I'm not, comfortable doing it, then there's a possibility that it can be a very overwhelming experience for me to go and talk about such a challenging communication. And there can be communication gap or misfire or aggressive reaction when I'm not able to deal with it in a right manner. There is no harm seeking assistance from your trusted colleague. Like many of you are saying, that when you have your people around you, it actually gives you support, it gives you a guidelines, it gives you an idea, how do you go about doing it. So before you go to disclose the facts to the patient or the family, it's important to review all available medical facts about the condition. Because they may ask you something, why did you do this, or why did you not do this, why did you manage it in this manner? If you know the case clearly, confidently, you will be able to answer their questions in a very matter of fact manner, which will actually help you gain their trust and also be viewed as a very responsible doctor who has done everything to mitigate this situation. So you really need to have a good knowledge about what this case is and what all has been done. I think we have to be really prepared to manage the strong emotions that are going to come from the opposite side. And simultaneously, within you also, there's going to be a lot of, emotional, fight within you. So you really need to be good at not only managing your own emotions, but also emotions of the patient and the family. So that's about preparation. Coming to the performance, when you're going to do it, it's important to, first of all, begin by stating that error has happened. You will see, if you don't start by saying that yes, error has happened, they will actually keep repeating to ask you, पहले ये बताइए गलती हुई कि नहीं हुई, पहले ये बताइए कि केयर में कमी हुई कि नहीं हुई. So they will not let you speak, they will not let you explain. I think there is no harm saying that something has gone wrong, rather than saying I have gone wrong, saying that yes, in patient's care something has gone wrong, or in the patient treatment something has gone wrong. So that actually gives them satisfaction that yes, we are admitting to what has happened. Then I think it's time to describe the course of events by using very simple and non-technical language, that this is what exactly happened and this is what we did, or whatever we did in the care. Use frequent pauses, because when you will pause, one, that they will get to assimilate whatever you have explained, because there will be emotional reaction coming from their side. And also you will see that they will have a couple of questions to ask you. So when you will pause, that will give them a space or a time or chance to ask questions. So when they ask a question, you'll get an idea what they're thinking or how they are viewing the situation. And then of course you can answer those questions and explain them whatever they're asking for. So telling about the state of the, nature of mistake, nature of the mistake or the consequences and the corrective actions that you have taken will give them an idea, okay, this is what happened, this is what you have done, and this is the possible outcome that we can expect. Now, for example, the way Dr. Venkatesh explained about this case, I'm sure in the same manner he must have talked to the patient's family and explained them everything. And the way he has actually explained that I visited in the evening around 10 o'clock or 11 o'clock, and this was my observation. I checked the pulse, I checked the tongue. I had a feeling the patient is, anemic, and I need to get the hemoglobin checked. So these steps, when you explain to the patient party or anybody for that matter, the person gets an idea that this doctor did his duty in a very meticulous, careful manner. So he has acted very responsible. He has really, done whatever he needed to do. When you explain things in this manner, that kind of demonstrates them that you have done everything in a very responsible manner. So I asked you this question about apologize, and some of you said yes, and some of you said no, that we should not apologize. I think the idea about apologizing is that we want to let them know we are not sorry. See, actually, apology has two meanings. And one is expression of compassion. So in case if something has gone wrong, so for example, in this case, there was no error. There was no error. So when you say, I'm sorry that this happened with you, or I'm sorry for the inconvenience that caused to you. So it's more of an expression of compassion or expression of empathy, where you are trying to say that I know it's bad and it has happened to you, and I feel bad for you. I'm with you. The second expression is expression of responsibility, where actually an error has happened from our side, and where you say that yes, this has happened and I'm responsible for this. And that is when actual error has happened by us. So the first one is always appropriate. The second one is appropriate when it is true. But situations have shown when you say, I'm sorry that this has happened, you will see you're actually disarmed the person. You have actually, by admitting that this error has happened, we fear that it might be used against us. But the follow-up conversation would decide how we, handle the situation and win the patient's confidence. A lot of time we apologize, but we actually not apologize. And those apologies in reality failed. So if I say something like this, if there was an error, then I think I would say it's wrong, but I don't think that was an error. So that means I'm apologizing, but I'm not apologizing. Or when you say there was a mistake, but the moment you use if and but, that means you are not completely admitting that again the apology fails. Or when you say the mistake certainly did not change the outcome. So it's going to add insult to the injury. So you're saying he was already in cancer, stage 4, so it wouldn't have changed the outcome. That's going to be very, very hurtful to anybody, and that's not an apology at any case. So, or when we say, see, in spite of all the care that we do, but human is to err, and sometimes these things happen. They are not going to take this as an apology. The apology has to be in a straightforward manner that, yes, I feel bad for you for what has happened. I'm sorry for the inconvenience caused to you. I'm sorry for what has happened with you. Of course, we have to choose our words very carefully, but the apology has to be unconditional when we are, apologizing. Take responsibility. Again, if you have failed somewhere and you know that this has happened because of you, when you use I statement, when you don't blame the team or the patient or anybody, and you take the responsibility, again, you are disarming the patient or aggressive patient party. So if it's not your fault, then don't accept it unnecessary. That's going to actually, kind of give this feeling to the patient that you're guilty of what has happened. But then taking the responsibility by using I statement, you show ownership of the situation of the case. Step 5 is invite questions. So inviting question will help you, first of all, know what are their concerns. Maybe if Dr. Venkatesh had asked the patient party, any concerns do you have? Quite possible this patient's attendant could have asked Dr. Venkatesh, will there be an additional financial burden on me? And that was the time where we could have addressed this concern and communicated that this is one of the possible complications, and there will be, additional effort and additional procedure and additional expenditure. I don't want to pass on the whole expenditure to you, but part of the expenditure or part of the burden will have to be, borne by you. I mean, in whatever way you want it, you could handle. So by eliciting question, by inviting question, you get to read patient's mind. You get to know what could be their concern. It could be, will the patient be fine? Will the patient recover? Will be any, lifestyle changes? Will it cause any permanent damage or irreversible damage? So when you allow them to ask questions, you get to know what are their concerns, and then definitely you can address them amicably. And that's again going to, create a dialogue and satisfaction for them that yes, their questions have been answered. Step 6 is make a follow plan. So that means whatever you discuss, whatever you talk to them, it's time to now explain them what exactly are you going to do now. So one is how are you going to minimize the damage, and also how are you going to prevent this to happen in future. So CAPA has to be discussed in depth, especially when they want to know, or especially when they have asked you, how will you prevent this from happening in future? Or how are you going to minimize the damage? So you really need to explain them in a very, a real sense manner. Then also discuss how to meet the needs of the patients and the family. Maybe they would like to see the patient. Maybe they would like to do some ritual. Maybe they want to ask you something or do something. So see how you can make that happen. See how you can, improvise those things. Then of course, even when you are leaving them, after you have updated them about the error or complication that has happened, tell them when you're going to update, how you're going to update, who is going to update. So if you tell them that I'll come back to you after the patient is stabilized and I'll let you know, or let me do the procedure and then come back to you and tell you this situation. So they would know that now they're going to be updated on a regular basis and proactively by. And then in case if they want to, get in touch with you, you really need to be accessible, approachable. They may ask you for your phone number. In such situation, there's nothing wrong in sharing your number. Getting your phone number is a minute's job. If you go to Google Drive, Google, or if you go to Truecaller, it's a minute's job to find out anybody's number. But in case if they ask you for number, and if you voluntarily give that, in case if you have something, message me and I'll get back to you. They'll feel that, okay, you are trying to, help and cooperate and provide as much support as possible. Whatever happens, again, documentation is something that has to be kept up to date. Whatever communication you have with them, that has to be updated on regular basis. When you're disclosing error, if you're disclosing, this communication to the patient, that incident has to be reported. First of all, report the incident, what exactly happened, what actions you took to minimize the damage. Then the rationale for the clinical decisions that you took at that time. Now, for example, this case Dr. Venkatesh has shared with us, the way he has rationalized his, treatment plan, it looks so very realistic, so very, in the interest of the patient. Anybody will be convinced with the steps that he took, or the final action that he took to do the explorative laparotomy or the second, surgery. Then, of course, document the clinical outcome and the next plan of care that you're planning. The discussion you hold with the patient and family has to be actually documented as it is, especially the names of the people with whom you have communicated, the relationship of those people with the patient, so that who all were engaged or involved in the discussion. The pertinent questions that they asked and the answers you gave, even those should be documented, so that it kind of comes as an evidence that you replied to these questions in this manner. So you have created evidence for not just the questions that they have asked, but also the answers that you give to the patient or the family. When the whole incident is over, it's important to sit and reflect back. Debriefing is very helpful to actually learn what needs to be done in future to prevent something similar, and also to minimize the damage to us and to the hospital and to the patient. So sit back to self-checking, see how you're feeling, check your hot button, see how you can manage the same situation in a different manner in case if something like this happens in the future. Do not hesitate discussing with your colleagues. Usually we shy of, talking about what happened. We think, people might think I'm careless, I'm just irresponsible, or I'm not competent, but that's not true. All of us go through something similar. I'm sure in initial couple of, my training programs, I shared with you the debacles I have seen in my own training programs, the failures that I experienced or the shortcomings I experienced. So when I shared with you, the idea was, when you will be taking session, you should be able to, see that these challenges you might experience. So similarly, whether it is the failure in disclosure of error or failure in managing the situation, both should be discussed with people with whom you are comfortable talking, taking their advice, taking their help, understanding how they would have handled it. That will give you an insight to improve your, health, functioning, and also future incidents, how you can manage it. So this is in a nutshell about how you go about, disclosing the medical error. Just to summarize the steps that we have discussed, I said, prepare yourself, check in, and then when it comes to performing, state what happened simply. Apology does help. I'm going to show you two videos, very beautiful videos done by two Indian doctors, who are very passionate about teaching communication. Dr. Praveen has already seen them because I'm sure he was part of the training. So that shows, how the whole communication would change. If you will see these two videos, you will agree with me. And then, of course, take responsibility of what has happened. Whether you take or not, they know you are responsible. But the moment you take the responsibility, there is nothing left for them to fight with you for. And if you think, if I take responsibility, they can take me to court, In case if they have decided to take you court, they are going to take. Again, there you will have to fight your case and prove that you have done your job well. But taking responsibility would calm them down and disarm them. Inviting questions will give you an idea what they are thinking or how they are taking the information. Make a follow-up plan where you would tell them how they would be get updated, on regular basis about the condition. Document whatever has happened, and then finally debrief so that you learn from your experience and make things better. So this is, in nutshell about the at an individual level how we have to go about disclosing error. At the institutional level, I think it's very important to integrate disclosure, patient safety, and risk management activities on regular basis. So you'll have to really do a lot of mock exercises, practice session, having training programs, having discussion around it, so that this becomes something you can comfortably talk about. Of course, we need to establish a disclosure support system. So you will have people who are experienced at it. They can be part of the committee or support system who would see how we can do this amicably. Others can learn from it. So providing background, disclosure education, like we are discussing about it. When you will discuss with your own hospital staff the same topic, I'm sure they will be more understanding about how we can do it in a more effective manner. Then, of course, ensure the coaching is done time to time, have role plays, have mock exercises to actually make it happen. Just theory will not help. Once you will make them practice, they will be able to perform better. Create a culture of patient safety where patient concern or patient welfare is the top priority, and we don't fail to look after the patient safety effectively. Uh, Also create a culture of employee safety. A very important thing that I want to bring in here, which is probably now very often discussed on a lot of medical platforms, and that is concept of second victim. Second victim. I'm sure most of you know, the person who is facing this situation is also victim of the situation. And there is an emotional setback, emotional turmoil, emotional, ups and downs. So this person also requires help, support, guidance, counseling, emotional support, and assurance that nobody's going to, make you look small or irresponsible. So creating a culture of employee safety is also the responsibility of the institution, and also a culture where people report errors promptly without fearing the repercussion, and they should come out honestly and admit whatever errors happen, because once you will get to know that this has led to error, you can take preventive actions to prevent those errors from so that's how you can create a culture where patients, or not patients, people, staff feels comfortable sharing about the errors that are happened. And then of course use performance improvement tool to track and enhance disclosure. You can also have an observer. Somebody's device is not on mute mode. Can you please mute it? Thank you. So even you can actually have an observer to observe how the disclosure happened. And trust me, when you have your own team members observing you, you will get a better insight into what you did rightly or what could have been done differently. So that's also a way to improve your performance about disclosure. So again, this is a nutshell. Any questions about what we have discussed about disclosure, or any thoughts that you have to share with others? Thank you, Dr. Sheetal. Actually, this is a very important topic, and I think this should be discussed more frequently so that people become comfortable talking about it. Rather than covering, it's important that we start talking about it.
We need to develop this culture of a disclosure, ma'am. As such, we don't find this kind of a thing being discussed in any forum in the hospital.
Absolutely, absolutely. See, usually what we want to do is we want to kind of cover it up.
Yes.
So, I mean, although this is off the record, what I'm saying, if you think talking about something that has happened and has not harmed the patient and should not be shared with the patient, because as Dr. Puneet was saying, that if you share that, it's going to, unnecessary, uh, make the patient uncomfortable and anxious and also curious to know more. Off the record, I say, even if you don't do this, it's okay. But then ultimately there will be errors that you cannot hide. How would you handle that? Unless you learn how to handle it. And every learning has something to add, to improve our performance. So we really need to talk about these, comfortably among us so that we know that this has to be done. How to brief the patient posted for nasal sinus surgery that eyesight can be lost. So, Dr. Rajesh, I think this is what we were discussing. Probably you joined a little late. We were talking about the possibility of a complication. If the possibility of complication is very remote, and if you think that that needs to be mentioned, so like Dr. Sheetal had mentioned a case that, the possibility of a complication is 1 in million. So if I say that, see, the book says that there's a possibility of losing your eyesight, when you're doing, nasal surgery, because all these 4 organs are interconnected internally. Your eyes, nose, ear, and your throat, they are interconnected. And there's one of the remotest possibility of losing your eyesight. And I must tell you, but it is as much as possible as you're walking on the road and there's lightning and you get, killed because of that. Or bus wheel comes out and comes and hit you on head. So it's as unlikely as this. So you have talked about the complication, and you have also talked about the rare possibility of this happening. So it kind of reassures the person that, okay, that way too, I think even test dose can lead to death. And we have seen cases. I've seen patients dying during lumbar puncture procedure, which we consider like everyday work. So, but then talking about it helps them know that you are being transparent in talking about it. Even if you don't talk about complications, but you spend good 10-15 minutes addressing their concerns, asking them to ask questions. That gives them satisfaction that you just did not take signature in hurry, or you did not explain me well. So if you have spent 15-20 minutes talking about the procedure that you are going to do, how it is going to be done, what are the possible complications, they feel, okay, I think doctor has really explained us well. So that's the main, I think, the purpose. That's the main purpose. Any other question or thought that you wish to share? Absolutely. I agree with you, Dr. Himanshu. Giving time to the patients to ask questions makes a huge difference. I think that's one practice we have to, rather than giving information, rather than sharing information, always ask. There's a loop called ART. ART, ask, respond, tell. That means, and don't ask, do you have any questions? Don't ask this question, do you have any questions? This I learned from the training that I had with ACL. When I asked this question, they said, no, that's not the way. Please let me know what questions you have. Please let me know what more do you want to know. So that's the right way of asking, ask me questions. So because when I say, do you have any questions, it is a closed-ended question. A closed-ended question will get you an answer as yes or no. So that's not right. So ask, what questions do you have? What concerns do you have about your surgery? What concerns do you have about your treatment? What concerns do you have about your recovery? Be specific. So when you will ask questions like this, they will get an idea, okay, I can ask this question. And if you have kept 15, 20 minutes or 30 minutes to do this, if you have done your consent taking effectively, half the battle is won. Never do it in hurry. Never do it in hurry. Please let me know the questions you may have, is new. Absolutely. Please let me know the questions here. Absolutely. That's a good way. That's a good way. So the idea is, if I say, do you have any question? The answer is more likely to be no, because nobody comes ready with the questions. And you are not asking them the specific questions to ask them. Yes, Dr. Sheetal, I think you wish to say something. Go ahead.
Yes, that point regarding, sinus surgery, face surgery can lead to eye problems and all that. So I think, as surgeons or as anesthetists, we tend to do the same procedures over and over and over again. So what we've started in our institution is we actually have this typed out, the rate of complications and its possibility. And we tend to tick on that because it's really, really difficult, ma'am, to sit and write every complication for every patient. So it is a good idea to sort of sit down and say, okay, what are the types of surgery you do? And what are the possible complications? And what is the rate? So that, and one very, very important aspect that I tend to train my staff is there are two aspects to a consent. The consenting starts when the doctor starts talking about the surgery. She tells you about, what we're going to do, what are the possibilities, what are the risks, what are the benefits, what are the alternatives. Same as an anesthetist, I'm already talking to the person. The second part is जहाँ पे हम sign लेते हैं. तो ये two parts हैं. There is a confusion. Lots of my staff also says, अरे हाँ consent ले लो. It's not that you are signing. That person is just signing. However, the talking has already happened.
Yeah.
It's not like the consent has not, somebody else took the consent. It's not like that. So just to save ourselves, a good idea is to, हाँ चलो भाई इसको पढ़ के sign करो. At least you have said that. And also good idea to sort of put down your complications in written, like bleeding 1 to 5%, chance of post-op, headache 3%, something, and it's all documented. All these risks and everything are documented. It's a good idea. It can really help us, ma'am.
Absolutely. Absolutely. Thank you so much for adding that point. Thank you. Thank you. So any more questions or comments about this topic? So I'm going to show you two videos. One is, yes, Mr. Mohan, you wish to say something. I don't know.
Yeah, I totally appreciate Dr. Sheetal Dixit's concerns and the fact that there are so many people here who would be interested in understanding what the law in respect to consent in India, in our country is. The field is held by the decision of the Honorable Supreme Court in the case of Samira Kohli versus Dr. Prabha Manchanda, right? Now, what to say, how much to say, how to obtain consent. Kindly read that judgment. It's available free on the internet. Samira Kohli versus Dr. Prabha Manchanda, right? See, you are talking about the British laws and etc. etc. See, the fundamentals of all the Commonwealth countries, we have the same criminal procedure code, we have the same civil procedure code. Our law has evolved from the same, the genesis is the same, be it Singapore, be it the UK, etc. Now, Indian courts, with all due respect, we are very keen to borrow the Western principles, the Western standards. What we don't realize is the number of patients being catered to in the West is not the number of patients we are catering here in India. It's very difficult for us to make this point to the court whenever we, because the court is focusing and it thinks we'll have to actually shake them and tell them he was not the only patient there in that hospital or who came to see me in the OPD. See, there are various principles. We started with the Boehm's principle, then there was the Canterbury's principle, then the Montgomery principle. Law keeps evolving. And here, judges in India are quick to, take everything and say, yeah, let's put it here also, because it makes for a nice judgment. That's the order of the court. But how practical it is in the present situation with such a large populace in this country is something that we'll have to sensitize the courts. Now, having said all this, I still don't feel that the doctor should be too concerned, because in the Samira Kohli's judgment, which I just mentioned, ultimately it says that the doctor is free to exercise his discretion as to how much to say and how much to withhold. Because each patient, patients come with different kinds of background, socioeconomic, political, etc., etc. So doctor has the discretion to decide how much to disclose, but that should not be in total conflict with the fundamental principles. So if anybody needs to understand the real principle on consent, as the law of the land is with regard to the decision in Samira Kohli's case. Yeah, don't fear too much. See, there was another judgment of I think the National Commission or the Supreme Court that said, Dr. Sheetal Dixit was talking about printed formats. We said that so one of the judgments said there can't be printed format. No, come on, doctors are not going to be involved in patient care. They're going to be editors, script writers then. See, this is something this whole trend is bad. This whole trend is bad. See, if I have a family and I would like the doctor to concentrate and exercise his expertise in his field, not make him a script writer or be more concerned about how he's going to document things. Sadly, things are moving in the wrong direction.
Absolutely.
That's sorry if I've taken too much time.
No, that's all. So let me quickly share you the two videos that I said. So one is the bad way of disclosing, and then second is the good way of disclosing. Okay. So Mr. Mohan, Dr. Rajesh Talwar is asking for your phone number. It's in the group, Dr. Rajesh. You are part of the group and it is there in the group, Mr. Mohan's number. But Mr. Mohan, you can write your number in the chat and share with everyone, so that in case if they wish to speak to you, they can get in touch with you. Okay, so there we are. So this is the video on bad disclosure of medical error.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no, is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple, routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given the blood and bleeding is fixed. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see, watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her. But we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
So since we have talked about the protocol of disclosing the medical error, of course, it's again not an error. This case is not an error. It's a complication actually. But since we have talked about the protocol. What do you think was not okay in the video? What all you think the surgeon failed to do?
It should have been a closed door meeting because we saw other people sitting, and that is happening in the corridor.
That happened in the lobby, in the corridor. Absolutely. Lack of empathy. I think, Mr. Vijay, that's what you want to say. And
Yes.
it was missing. Yes, I agree with you. The way the details were shared was very, Dr. Himanshu, what do you think? What was wrong with the way the details were shared? Please unmute. Please unmute.
For me, it was looking like, just you have something to do with an explanation without explaining the details. Just you are passing the information.
Absolutely.
So it was in a very insensitive manner how the things were shared. Absolutely. And then when they're asking for questions, the doctor walked away. Yeah. Just listening what they're talking, he just walked away. So
good to be in hurry.
It was a very insensitive way of sharing the information.
Absolutely. Yeah. Yeah. Very right. Yeah. Very right, Dr. Seema. You say that somebody speaking.
Doctor also was trying to take an excuse under the guise of telling that there was a 1% chance of bleeding, and he implied that he had already told them that,
Yeah, yeah. So even if he had shared this, but if it has happened, it has affected a family, it has affected somebody. So even if it is possible, the way we are going to do is not like I told you and this has happened with you. So, I mean, it's not my fault. And it should have been in this separate room. I agree with Dr. Seema. Yeah, there didn't seem to be any preparation, or rather there didn't seem to be any training. He was probably prepared and trained in that manner, and that's why he was doing in a very unempathetic manner. Yes, Dr. Seema, I agree. The empathy was missing. Apology was it tendered? Did he say I'm sorry? No, he did not say. The tone of voice was inappropriate. Yes, I agree with you, Halal. He appeared very insensitive and not very compassionate and concerned. And in a very matter-of-fact manner, he kind of stated that there is 1% possibility. I told you already, and that is what has happened. I completely agree with all of you. So we could see the body language was not right. The way he was talking was not right. He was not using the right tone of voice. He did not listen to them. He did not answer their questions. He didn't ask what are their concerns. And there were two people. If you saw, he was paying more attention to the husband. A lot of time when we do like this, the other person becomes aggressive because he has not been given due respect or has not been engaged. And they can actually instigate the patient's immediate relative. So it's important to engage both the parties so that they feel respected and cared for. And that's also, something that we really need to do. Okay, yeah. So I'm going to show you the second video. Could the whole, disclosure be done like this? And the impact could have been very different than what we saw in this, video. Let me show you the second video.
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Unfortunately, I have some bad news to share. We've run into some complications into the surgery and we've had to shift Mrs. Kumar to the ICU.
What happened? What complications? Oh no, is she going to be all right?
I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure.
But this was supposed to be a simple operation. How could this happen?
Well, in order to do this operation, we first have to put a needle into the abdomen to build gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up.
Where did that blood come from?
The bleeding was coming from a major artery inside the abdomen. It appears that the initial needle insertion was responsible for the bleeding.
Who put that needle?
I put the needle in, and I'm very, very sorry about it. This just was not expected. We are trying our best to minimize the effects of the bleeding.
Is she going to be okay?
I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can.
When can we see her?
Well, the ICU doctors are working hard to stabilize her, and as soon as she is stable, you could see her. I will let you know. Do you have any questions for me?
Really don't know what to say here.
I can understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
One second, let me close it. So I'm sure there will be a doubt whether we should be admitting that this was done by me and I was the one who's responsible for the. So there will be a debate and there will be controversy. I leave it to your discretion how you want to really handle it. But if you focus on the verbal and non-verbal part, he appeared to be more sensitive and more, compassionate in his approach. And that's what probably I'm trying to, emphasize, that if you're able to build that kind of relationship with the patient party, they're less likely to be aggressive. But of course, we all know the reality is a lot of time they have hidden agenda of making money out of it, asking for compensation, asking for discount, asking for waiver of, the treatment cost. And they are real life challenges. I completely agree with you. And they need to be proactively managed so that you can minimize them. You can minimize. So any questions about this topic? Yes, Hilal, I think it was a good observation that the conversation was in confidential place, empathy was there, good tone of voice, explained the whole procedure clearly. Yes, I think you're right. And he really tried to answer their questions and satisfy them, and also close the loop by saying when and how they will be updated on the next lesson. So if there are no questions, I think we have a couple of presentations. Who all are ready with the presentation? It's already 10 past 10. Okay. Maybe you would like to take the presentation? And then I think Dr. Sheetal, Dr. Dikshit, you are ready because I have not seen your presentation. Okay, so there's a question from Dr. Himanshu that ways to standardize such protocols. So can you please mute your device for a second? Yeah. So, Dr. Himanshu, we are usually following what we get from the Western world. But I would recommend that we really need to customize that to our Indian healthcare delivery system. Our clientage is different. Our healthcare delivery system is very different. I mean, even if you pay a focused attention to the whole concept of preparing a protocol, you can develop a basic one to start with and keep refining it with time. That's the way I would recommend. We can use some guidelines as a from the Western world as a baseline and modify and customize to our need, and then keep correcting it. Like in NABH, what we do, we have a SOP, and then we keep improving the SOP, and we make additions and deletions. So that's how we need to work on it. Protocols for us should be prepared by us. That has to be the approach. Only then we will be able to come up with something that works well for us, and we are not just copy pasting the Western protocol. So Dr. Seema has asked a question. How do you manage if the party really wants to create problem after sensing our mistake? So for example, if they kind of blackmail you by saying that I'm going to take a legal action. Again, in the spur of moment, you'll have to take a decision whether you really want to go ahead with telling them do whatever you want to do, or maybe telling them, see, going to the court is not going to undo what has happened to your patient. When I am assuring you of the best possible care or the corrective action that we can do or minimize the damage, I think we should focus more on the patient's welfare than talking about the going to law. And in case if you still want to do it, you're free to do it, because in any case, if they want to do it, you cannot stop them. We cannot stop them. But when we are able to shift their focus to the issue rather than to the to the anger or the way they want to take out their anger, yet at times that really helps. When they see you proactively coming forward in supporting them or finding ways to look after or to see how you can minimize the damage, that also softens their approach. They feel that, okay, unfortunately this has happened, but then I think whatever needs to be done, you are doing it proactively, so I'm okay with it. So again, there is no one line answer to this. You'll have to really see, maybe if they are doing it with the agenda to get some compensation or to blackmail you to get money from you or to get the waiver, then probably you'll have to take a strong stand and say, see, I haven't done anything wrong. You can go to court, you can call police, or you can do whatever you want, but I know I have not done. So again, something like this may help you in that situation. And a lot of time, even if we haven't done anything wrong, but we know going to court, engaging lawyers and visiting court is not easy. It's not easy. Even if you haven't done anything wrong, you would rather say, take the compensation and go and don't come back with me. So that's probably case to case, you will have to see how you want to handle it. In reality, that's the thing. I've seen a lot of people paying under the table, even if they have not gone wrong. But they know going to the court is not easy. It takes a lot of your time, energy, money. So they say it's better to pay it and let it be. I got my house vacated by paying the person who was on rent for years with me. In spite of the fact that I had gone to the court, but then I realized that's not the remedy, because court is not going to, give me a decision overnight. I'll have to go 100 times to the court and, spend that time and energy. I said, better give this money to this person and get rid of it. So rather than that, I would ask you to focus on how can you strengthen your processes and procedures in a manner that you can, minimize such cases in your center. That's what I'm trying to, focus on. Okay. So, Dr. Hilal, are you ready to present? Mehdi, are you ready to present? Okay. So should I give the feedback form now so that I get the feedback for the session, or you want me to send the feedback form in the group? Because lately sometimes people become lazy and they don't give the feedback. That's why I think that feedback form should be done before we start with the activity. So please bear with me. I'm sharing the feedback form with all of you. And I request you to share your feedback before we move on with the presentation by Mehdi. Give me 1 second to copy the feedback. Okay, there we go. I've shared the link for the feedback form for this session. So please go ahead and complete it. So I've received 7 responses as of now, waiting for all others to complete. So I've received 11 responses. If you could raise your hand and show who all are still doing, I would know that we have to wait for you. Okay, meanwhile, I am giving the screen sharing access to Mehdi and also Dr. Sheetal. So you can.
Thank you, ma'am. Am I audible to everyone?
Yes, you're audible. Yes. And we can see also your screen.
Okay. Is it visible to everyone and am I audible to everyone?
Yes, it is visible and audible also.
Okay. Hello, everyone. I am Mehdi from Bangladesh. I am serving as a senior assistant manager at Epic Healthcare. As the presentation topics, today we will discuss about ice breaking. So first of all, I will show you some ice breaking slides and later on we will discuss some form of ice breaking activities. Because of time shortage, I will not linger it. So let's start from the presentation slide.
So can you bring it to slideshow?
Yes. Is it visible now?
No, it's not on the slideshow mode. It is, we can see the slides, but not on the slideshow mode.
Now it's okay?
Not really. This, we have moved to the second slide, but we have not gone to the slideshow mode. Yeah, you need to do this.
Is it okay now?
No, I don't think. So maybe you can increase the size by clicking on the plus at the bottom, right bottom. You can increase the, in case if it is not moving to the slideshow mode, you can increase the size by touching the plus sign on the bottom. It's okay if you go ahead like this also, it's all right. Go ahead, please. Yeah.
Okay. How icebreaking activities boost up your team performance? Icebreakers can be an effective way to help teams get to know each other and feel more comfortable collaborating.
Please show the next slide. Sorry, Hilal. Sorry, Mehdi. Please show the next slide. You're on the slide 1. Show the second slide.
Actually, this one is first slide.
Okay. This is slide 1.
Yeah.
I thought you were reading second slide.
No. Okay. How icebreaking activities boost up your team performance? Icebreakers can be an effective way to help teams get to know each other and feel more comfortable collaborating. It's important to choose the right icebreaker for your team. Teams that know each other well may be more comfortable sharing personal information. Benefits of an icebreaker. They can help to create.
Mehdi, we are not able to see the slide changing. We are still on the first slide, that is ice breaking. We have not been able to read the second slide, and you have moved to the third slide now. Yeah, now yes, we are with you. Yes, move to the next one now. Yeah. Benefits, yeah.
Benefits of icebreaker. They can help to create a relaxed environment where participants share ideas and participate more fully in the class. Encourage participants to share ownership for the learning environment of the class. Build rapport among participants and foster a productive learning environment. What are the objectives and goals? Meet new people and know about them. Help participants to feel at ease. Create a non-competitive environment, having fun. Icebreakers' 3 characteristics. A meeting was scheduled for a reason, therefore it won't matter. Sense of icebreaker would take up too much of everybody's time and risk delaying a project. It has to be simple. Again, complex activities would take up time. Think twice activities that can easily be explained and easy to understand. Include a get to know you element. Remote employees situated in different geographical locations don't get as much chance to get to know their teammates, unlike if they are in one physical location. The only way to know them better is through icebreakers. Some pros of icebreaking: motivate team, active learning, bring new ideas, learn from team, high engagement. There are different forms of icebreaking activities, but I not taking so much. I just, maybe there is some fun questions format, there is some personality quiz. So in this session, I select some questions for the participants. I saw here are 16 participants, if I am not wrong, but currently I am seeing 13 participants. So I am showing some questions. I just need your participations whenever I asking you the questions. Is it okay, ma'am?
Yes, you can. Yeah, go ahead, please.
So here I open some questions.
So Mehdi, I think maybe one or two questions would be enough to give everybody a feel of what exactly you mean.
Yeah.
So maybe
actually,
you could ask
I just want to, anyone can raise your hand and take a questions, and I will ask. Anyone can raise your hand, so either I can ask you a question. Anyone?
Okay, Mr. Mohan has raised his hand.
Okay, Mr. Mohan. So I am picking a random question. Is that okay?
Absolutely fine.
Okay, thank you. What's one thing you want to do in life but don't know where to start? If you don't understand, I can repeat.
I'd like to live in the wilderness. So I'd like to go and live in a forest.
Okay.
Away from civilization.
Okay.
Yeah, that's one thing on my mind always.
Thank you.
Thank you.
Maybe I can ask another question to you.
Yeah, please go ahead.
Okay. So
can I answer the third one?
Third one, sure.
Yeah, I'd love to have an elephant as a pet.
Elephant as a pet.
Absolutely.
Why you select such a giant pet?
It's lovely to ride an elephant. Of course, the poor animal is not going to feel happy, but I'd love to sit on an elephant and go through the wilderness. Just a fantasy.
Yeah.
I've always fantasized such things since childhood. Thank you.
Thank you, Mohanji. Thank you.
Thank you.
Would you like to answer any other?
I don't know if others would. Dr. Sheila seems to.
Sheetal has raised. Yeah.
Sheetal, are you interested to pick any question?
Sorry, Dr. Sheetal, sir.
Dr. Sheetal?
Unmute your device, Dr. Sheetal.
Yeah, so I'd like to answer the question on if I had a superpower, I would like to get into my son's brain and think, see as to what he's thinking of all the times. It's very difficult to figure out teenagers.
So should I ask you?
Yeah, so yeah, sure, absolutely.
Okay. What's one thing you want to do in life, but don't know where to start?
I want to have my own hospital, but I don't know how to start. Unfortunately, people say that I don't have the financial or the that acumen. So that's what I would love to have a hospital of my own. Yeah.
Okay.
You're a very gutsy woman.
Yeah. the guts are there, but the other things need to follow.
Number six is okay for you. Would you like to take it?
Yeah, sure.
Number 6, how do you recognize yourself when you are stressed?
Problem is I can't recognize myself when I'm stressed. It's the total wrong me that comes out, I think. So I don't think anybody should recognize themselves when they're stressed. It's
yeah.
Just what I think.
That's a very good answer.
Interesting answer, Dr. Sheetal, very interesting answer and very thoughtful answer.
Thank you.
Can I continue?
No, I think, Mehdi, thank you so much. It was a wonderful ice-breaking activity you did at the end of the program, but you engaged everybody and everybody became excited and interested in the way you ask questions and the kind of questions you are asking. Very interesting. We are actually quite late. It's already 10:30.
So yeah, ma'am. It's already late.
Yeah.
Thank you, everyone. Sorry, and it's been a nice journey since we are together in last 10 weeks. But unfortunately, we have to say goodbye after these sessions. But it's not about goodbye. Maybe we can contact with each other in different form. If there is anything, any course in near future conducted by Dr. Induji, so maybe we will together again.
Thank you, Mehdi. I think that was very kind of you to have said this. Thank you. So if you can stop sharing your screen, yeah. And I think Dr. Sheetal also has. Dr. Sheetal, how long will be your total presentation? Unmute your device, please.
Yeah. I am unmuting myself.
I just need to, just a minute, share my screen. Yes.
So first he has to stop sharing, only then you'll be able to hear. Yeah.
Right.
So maybe you'll have to stop sharing. So are you trying to show some video, Dr.?
Yes, ma'am. Yes. Is it possible?
I don't think that you have access to your video.
Oh, okay. Can I, is this visible? Sorry.
So it's saying that couldn't preview your file. And there's a problem playing this video.
Just a minute.
So it's not downloaded on your laptop?
It is, ma'am. It is. In fact, I can see it. I don't know. Should I be? 1 minute. 1 minute. Hang on. Yes, I'm saying new share. Can
Dr. Shital, in case if it is taking too long, maybe you can try seeing if it works. Meanwhile, can we stop sharing and I may quickly have the feedback of people about the program, because it's the last session and I really need to listen to everybody's thoughts about the program. If it's okay. You are on mute mode. Your device is on mute mode.
Right, ma'am. I think we should because I think this is not working.
Maybe because the software is not compatible with the videos software, so that's why.
Okay, so I have this downloaded.
Yeah.
Not a problem, ma'am. I'm not. I'm going to just stop sharing. Yeah, go ahead.
Thank you. So with this, I think we come to the end of the.
If Dr. Sheetal could share it on the WhatsApp group, would that be possible sometime? Sorry for the interruption.
Yeah.
Yeah, I'll just share that. I'll just share my entire thing. Yes, absolutely.
You could do it later, Dr.
Yeah,
Sheetal.
you can do it after the session.
After the session.
Yeah, after the session. Yeah. So this is the last session. It's really difficult for me also to bid goodbye to all of you. I'm sure. I mean, all of us have been connected for so long that it looks like more like a family. And every time we meet, we think, okay, this time this discussion is going to be really lively, and it has actually always been. I mean, I've really benefited from everybody's sharing of their experiences wholeheartedly, learning from each other, and the humbleness that all of you have shown by attending this program with so much of sincerity and dedication. I really want to thank all of you. So if some of you wish to give any feedback about the program, you wish to share your thoughts about the program, I'll be really happy to listen to you and get insight into how I can make things better in this program. So who would like to take the lead? Okay, thank you, Dr. Himanshu. You can please go ahead. Yeah.
First of all, thank you so much for keeping us engaged with this wonderful journey of communication in healthcare. And if I see from day one till today, almost every aspect of healthcare communication have been addressed in a much bigger way than anything before what I could have been experienced. And it's not only listening to you, I am implementing the thoughts what have been shared by you. So that has made a difference. And I have realized that small things which probably we overlook are the things which are possible to correct. And if we see healthcare, often the issues are happening when we are over promising and underperforming. So we have to be very, very clear in our deliverables versus our promises. None of the patients says that they need to have 100% documented, outcomes.
Yeah.
But at least they appreciate if we are 100% transparent.
Yeah.
And that creates a huge change in culture of the organization and also in thought process. Another important thing which probably I have evaluated within my own organization over a period of time, that if we take healthcare as a service versus healthcare as a business, it makes a huge difference.
Absolutely. Absolutely.
And, probably healthcare is next to defense services, where the word service have been used. Rest all are businesses or the professional, areas to work. So probably it is embedded with the healthcare service that people look for favorable deliverables. And when they look for favorable deliveries of our services, the expectation is also picking up, and they assume that when we are reaching the doctors, the answer has to be yes, the patient will come out of every situation. So that's where it's a wonderful framework what you have created, ma'am. And the videos which have been the power of explanation between good and bad are very good. And I have seen those videos earlier as well. But the narrative behind those videos has given a lot of explanation with your own experience. And I'm sure each one of us would have a lot of value addition through this course of few weeks. And I'm looking forward if you have any more such courses to encourage the healthcare leaders. And as I said, and I asked you also that, are there any standardized protocols? Probably in few years to come, whether you like it or not, that standardization would be the need of the hour. We may not be able to sustain because the people are becoming aware day by day. The patients and the relatives are knowledgeable enough to have set of questions ready for them, and they know what are the pros and cons of a specific procedure. So it's always on a better side that we stay with the transparent communication, a healthy communication, and involve the patient and relatives in decision making, so that we are able to have a very healthy healthcare deliverables and healthcare services with a huge respect coming back for the whiteboard. Thank you so much.
Thank you so much, Dr. Himanshu. I think very kind words that you have spoken about the program, and for everybody, I think, and we have all learned from each other. And I wish to continue this journey with all of you, and hope to see you again in some program and be together with all of you. Thank you. Thank you so much. Thank you. So if there's anybody else who would like to share their thoughts, I'll be happy to, listen to you. I think Dr. Venkatesh wants to say something. So please unmute your device, sir. Okay. Hilal also wants to speak, and okay. Thank you so much. Yeah.
I did have a lot of apprehension just before joining this course as to what value addition it would have from a clinician's viewpoint, because most of the people who get into this course, apart from specialists, it would be in other occasions also, and largely into domain of administrators, hospital administrators. Most of them in our batchmates, where some of them were also managing hospitals. I mean, they would have had a broader perspective. But today's my one-to-one discussion with you and the open forum I had now with my course mates really has opened up new vistas, in that the learning is something which is very continuous till we hang up our glove boots and say we quit, and we go into wilderness, as Dr. Mohan aspires to, or pursue something which is very close to our heart, because 2 or 3 or 4 decades of practice can really it's a mixed bag. You get bouquets. I being a gynecologist in obstetrics and women's health, I'm into the domain of women's health. Most of the time it is bouquets.
Yeah.
Very rarely it is brickbats. So having got used to that kind of you are in a demigod kind of a thing. Whether you like it or not, you are next to God kind of a thing in our specialty. And there's very least acceptance for any minor derangement from the normal outcome. And having said that, the incident that which I went through is again a real eye-opener, in that you told that periodic briefing regarding the financial aspects would have to a large extent, if not avoided, but then it would have been, that was one thing which there was a glaring omission from the hospital side or my side also, because I'm also equally responsible. I can't put the blame on the financial administrative part, because being the head and director of maternal and child health services, I had to follow the due diligence, which I think I omitted there. But this is an excellent program, madam. I just wish that if there are additional, such courses or extension to this already what we have been taught, we would be more than happy to be part of the course, and we would like to disseminate this information about this course to our regional societies, bodies, and I would want you to visit Bangalore on this pretext, at least in the coming weeks or months, and I will be in touch with you. Thanks for the excellent course.
Thank you so much, sir. Thank you. I think these words coming from a very seasoned practitioner like you is very humbling for me, and I really look forward to long-term association with all of you, and to take this program to to a level where actually we have more people who are equipped with these skills and who are ready to impart this knowledge to everybody and anybody who is working with patients. I think that's the whole idea of this program. Thank you so much for your kind words, sir. Thank you.
Thank you.
So if I may, I think we have 3 hands. So I think we'll ask Helal to speak, because we need to hear somebody from the neighboring country. What do they think and what does he feel about the program of the session? Go ahead, please.
Thank you, ma'am, for giving me a chance to talk about this program. Actually, I'm being so much emotional right now. Since I couldn't participate as other participant of this group, like Dr. Sheetal Dixit, Dr. Vanshi Kumar, and any other member of this group. I have learned so many things actually from them, and you may not believe me that when first class has completed, I have started practicing all this after the first class actually, and my organization Epic Healthcare has getting the result very effectively actually, like talking with a patient effectively, efficient communication, and how to manage critical situation. Most importantly, we had a problem of sitting arrangement in our administration department. After this, we have actually started sitting the patient in front of us and started talking with them, and so many problems we are solving in this way. Wow. Actually, thanks to all of you, those who are here, and actually, I'll miss all of you, and I request Madam to continue these types of program, and so that we can participate accordingly. And lots of things I have learned from here, and what I'm saying, we are getting the result actually, and it's rising trend actually, and we are so much happy that we are learning and trying to give we have done so many programs actually with that. After finishing one class, we have done a program in our organization. So thank to all of you. Actually, I'm not ready to talk with you right now, because I'm getting so much emotional, because it's the last class actually. So I'll miss all of you. If there is any wrong from me, please forgive me. I'll miss all of you. Thank you.
Thank you so much, Hilal. Thank you for kind words, and knowing that you have started implementing what you are learning from the program, and yes, you're finding the use of it and benefit of it. It's very encouraging to all of us. And I'm sure each one of you must be also trying at your end to implement whatever you are learning.
You can charge him extra fees now.
He has been a silent learner. He has always, quite heard everybody.
Yes, he's very good. He's
Yeah.
a good learner too.
Yeah.
And we got so many what do you say, like, actually I can't say anything because I'm getting so much emotional. That is why I'm sorry. I will not take
That's
more than time. Thank you.
Thank you so much. Thank you.
Salam.
Thank you. So if I may request Dr. Sheetal to share her thoughts.
Yes, ma'am. Thank you very much. I must appreciate what you do. I'm really overwhelmed to sort of do a class with you like this and do a training session with you. You've been actively involved in teaching students. I think people like Shahrukh and all are really, I think they're really lucky to have such kind of training right in the beginning of their careers. I wish we had that. We really never thought that communication should be a part like we did medicine and surgery and everything. So I think it should be definitely a part of teaching. And yes, given that we were doing our communication sessions, I could actually teach my students as well, because they actually in their DNB curriculum have during their practical exams have sessions on communicating bad news and communicating consent and all these things. So thank you very much for that, and I could actually give them a sort of a stepwise guide for that.
Structure.
And definitely a structured program. So at the end of the day, we say, communication, well, whose domain? Is it my domain? Is it the administrator's domain? I think it's everybody's domain. And thank you very much for inculcating that into us. I think it's very, very important that all of us just put it in the way it is and in a structured way. And thank you for that. Thank you very much. I'd like to meet you sometime. Definitely.
Definitely.
Thank you.
Definitely. Thank you so much, Dr. Sheetal, for your kind words.
Thank you.
And as and when you need any help or any, this thing, I'm always there to help you or to support you wherever you need. Thank you so much for your kind words. Thank you. Yeah. So I think Mr. Vijay, you have raised your hand, so you wish to say something. Please go ahead.
Yeah, sure, ma'am. Yeah, it will be quick. Thank you so much, for the session. Actually, see, I think I am not from the healthcare field. So I started with a lot of inhibition, right? What I would be learning here, is it really useful for me? But all the 10 sessions actually are real eye openers for me, right? Because I could understand how healthcare communication works. Right, and also it is not a theory part. It is all real life examples, like all the like all my teammates, they all gave the real life examples. And then Mohan Hasser has given a legal touch to that. And it was really very engaging session. And I am a trainer, right? And I know it is so difficult to engage the people, especially in the virtual sessions. And what I found is, you have really engaged all of us, though it is a very virtual session, right? So I really must appreciate, you for that, madam. Really, I mean, I could learn a lot of things, how to engage the virtual, participants. And it's really, I mean, definitely it is a big learning curve for me, I would say. From where I started 10 weeks back versus where I am now. And definitely it expanded my scope of operations, right? In terms of trainings and all. Thank you so much, ma'am. And thank you all my teammates.
Thank you. Thank you so much, Mr. Vijay. I think very kind of you, because when he joined the program, he was little skeptical. Will he be useful? Will he be benefited? Will this program be useful? But thank you for trusting me and then being with us. And all of you have been excellent audience. The way all of you have stuck with the program and stayed with me up till 10:30 night, it's not a small thing. And I know next day morning is your working day and you have to get up early in the morning and then get back to your routine. But the kind of sincerity and dedication that you have shown has really given me a lot of confidence in my work, and I'm sure that's going to raise the bar of audience actually You have raised the bar for the audience that they really need to, because I didn't expect people like you who are so well placed to, attend it with this much of seriousness and participate. It has been a rich learning experience for me as well. So if there's no one who wants to say anything, should we say good night and bid goodbye to each one of you?
I think there is an audience request that Mr. Ranti Mohan should speak some words.
Okay. So you actually have been a cherry on the cake, Mr. Mohan.
Thank you so much. I'm very humbled. A lot of learning experience for me. I have known Dr. Indu because we attended a program together in Mumbai. Excellent. One thought, a few thoughts. I mean, this was an impromptu. So I understand the magnitude of the problem concerning communication in the healthcare industry. And I also appreciate the fact that people have now come to realize that there is a need to improvise, learn and improvise. Yeah. Then the thought is that my new learnings from this whole session is that there are not only methods to mitigate problems, but there are real solutions. Yeah. So this is what I want to say. Nothing else. Thank you so much.
Thank you so much. Thank you so much. Again,
there are solutions. There are solutions.
Absolutely.
And the peer bodies like the FOXI, for example, for the obstetricians and the Association of Anesthetists, etc. These peer bodies must do the lobbying, the flag bearing responsibility. Yeah, it's not individual doctors who can really bring about change.
Absolutely.
The peer bodies who must make a change.
So, Mr. Mohan, when you say there are solutions available, I think we have to move with the approach. Even if there are no solutions available, we have to find those. We have to search them, and we have to instate them and reinstate them so that the future generation do not suffer the consequences of what has happened now. Actually, a lot of damage has happened to the healthcare and specifically medical profession. And
one
we
more thing.
To take the responsibility to correct the situation. I think that has to be the approach. Yeah.
In the legal fraternity, we say that you should not only know the law, but you should know the judge also. Yeah. So similarly, in the medical field, you should not only know medicine, but you should also learn to know the patient. Absolutely. And his attendants. It's a big task. Thankfully, I'm not a doctor.
No.
Thankfully, I'm not a doctor. But my prayers are with all the doctors. Thank you for being doctors.
Thank you, Mr. Mohan.
As you rightly said, Mr. Mohan, it is so important that we generally take it for granted. All this thing, like we never think that communication is so important. But as for in my personal case, from the time we have started these sessions, being an administrator myself, I thought that I know everything, but then I knew nothing. Basically, if I have to see personally, whatever madam has taught all these while, I was trying to relate where all we are missing on each and everything. It could be it could be the role play, it could be the communication part with the doctor, it could be a HR communicating with employees or doctor communicating with the management. So each and every point was very valid, and thank you, ma'am, for giving it such opportunity to learn from you. And it was very, very important and very, very healthy discussions which we have done with all our teammates, and very nice of you all that we are all being a part of our team, and very sad that the sessions got over very fast within a few very like it was very fast. So thank you again, ma'am, and we'll definitely be in touch with you for any of our further sessions or something if we have to do anything on our communication part. But really a very, very helpful sessions all. Thank you, ma'am.
Thank you so much. Thank you,
ma'am. Ma'am, are we going to?
Before you conclude, madam.
Yes, please. Yes.
I would want to acknowledge and tell you this fact that I was inducted or induced into this program courtesy my friend NC Mohan,
Yes,
who invited me on the first day to this session of yours, and I joined a day later. So, but for his thing, and he went as far as telling that he will sponsor my course fee, which I mean, that's his goodness. I mean, we are great friends, and he's been with me for last decade or so, and we together form a very synergistic
absolutely.
association.
That's a deadly combination. Let me tell you, that's a deadly combination, and it definitely will work, for the good of the profession.
Ma'am, I want you to give us certificates, ma'am, which I can flaunt in my office.
Absolutely, you all will be getting your certificates.
Thank you.
Within a week's time, because it requires, writing on the soft copy. So I'll get it done and then send you. And since I'm in India, so it should not be a problem now for me to.
Thank you. Thank you.
Dr. Praveen has written in this, although I would have been happy if he had, unmuted and also had the camera on and spoken. But thank you for very kind words that you have written, Dr. Praveen, that it is an excellent program, very well designed, and the dedication is outstanding, from reading individual chats for discussion and to taking feedback seriously. And the teammates have been wonderful, so much of knowledge breaking and sharing, lifetime changing learning experience. So thank you so much, Dr. Praveen. I think again, coming from you, who has already done program with Kaho, and Dr. Praveen himself is a trainer. He himself is a trainer in communication. And when he said he wants to join the program, I said, why do you want to join? You're already a trainer. So what is it that you're going to learn new? But I'm really happy that he said that I want to revise my concepts and I want to, I really hope that you found it useful and meaningful, and it added some value addition to your program. And if you wish to say something, please unmute and speak.
Definitely, ma'am. The program was, as I typed it, it was a very structured program. The Kaho program which we have attended, and once even we give a very short sessions, they are not like for 10 days, and the amount of knowledge which you have given definitely makes the person more confident. So definitely it's a very nice program. I would be recommending the program to all my colleagues and friends.
Thank you so much. Thank you.
May I, ma'am?
Yes,
may I, ma'am? Yeah.
Yes, ma'am, please.
Actually, you know what? The communication, what we thought was so simple, but it has so much into it. Never thought of unless you really gave us insight into. I mean, it's such an in-depth thing, and the learning was really good, I must say. And you have been a great teacher, and even the other colleagues had also taught.
Absolutely.
In a similar manner.
Absolutely.
And thank you so much for that.
Thank you so much, Dr. Seema. I think you have not known me, but just trusting the reviews put by people and your own gut feeling that this program will benefit you. You joined the program. I mean, I didn't have any interaction with Dr. Seema. She just, sent me the details and she paid the fee, and then she sent me the screenshot that this is where I am. And I was really very happy to see that this is the amount of trust now people are having in the work I'm doing. And that encourages me to give my best so that, this program actually becomes a signature program of IAFC, and more people, although I had announced that this is my last session for this year, but by now I've already received around 6 or 7 people who really want to do the next program. And I may have to announce the next program because I don't want to break the chain. The reason I was trying to, put a pause on it, I thought maybe not very many people will be keen to attend the next program. And also it's my daughter's wedding in December. So I wanted to give single-minded attention to the preparation for the wedding. But then my daughter said, no, you don't have to stop working. Your work should go on. The show must go on. So you must announce the program. So hopefully I'll be announcing the next program in the month of August. As a result of this program, I'm getting now invites from the hospitals who want to do exclusive programs for their hospitals. So for example, for Reliance Foundation Hospital, I'm training 15 people. Already we are on the session 6, I think, with them. Similarly, another hospital in Hyderabad has asked for 12 trainers, 12 people to be trained as master trainer, and they want to do the program on site. So I will be most likely going to them for 2 days and rest of the sessions we will be doing like online with them. So I'll be announcing the program, and if you wish to recommend to somebody who is seriously interested to learn and is really dedicated and is passionate, I'll be happy to have them. You can recommend them, and you can share my number with them or share their number with me, and I can definitely, correspond with them. But I think you all have been excellent audience. The credit cannot be just mine. The credit mainly goes to the audience. Had you not participated, probably my energy to deliver so much couldn't have been this much. In spite of all adversities, me being in US in different time zone, but then seeing your dedication, I said, I have to give my best. Shahrukh has written a comment. I think, Shahrukh, you are the youngest participant, if I'm not wrong. And one of our favorite one, although a lot of time you could not attend because you were on emergency duty. And you have written, it has always been a good experience to be a part of this program by Dr. Indu Ma'am. This time it was wonderful to learn from all of you as well. Yes, I think that has actually enriched the program. Thank you. Thank you so much. Thank you. Shahrukh, if you wish to say something by unmuting, because you have a very beautiful setup, you can always, unmute and speak. If you wish to say something, please go ahead. Yeah.
Sorry, I was not very regular in the program, but I was just listening it most of the time, and to the recordings also, and it was a really wonderful experience to learn about all the experience of the all the experienced people here. So I have been through the program 2 times, as I have already said. So it was more of the discussions that we were going through. They were a lot of knowledge was imparted through them.
Absolutely.
So thank you, everybody.
So thank you, everyone. It was really wonderful connecting with each one of you. And it has been rich learning experience for me. You all have been wonderful audience. And we can always stay in touch. The group, I'm not going to wind up the group, although I know we will never be putting any unnecessary messages. But then I'll keep the group alive in case if you have something important to share or discuss, please go ahead. And in case you are organizing any program, you need some guidance from me, I'm just a call away, message me and I'll call you back, and we can design your program. And you can execute the training on your own if you think you want to do it. Or if you want to involve me or engage me, that's also one of the possibilities you can explore. And let's all stay in touch and see if we can meet anytime in the time to come. Thank you so much.
Thank you so much.
Thank you so much. Thank you, everyone.
Thank you. Bye-bye. Good night.